In the time it takes you to watch this opening sentence, somewhere in the United States, a brain just went dark. Every year, stroke kills nearly 160,000 Americans. It is the fifth leading cause of death in this country, and the single leading cause of long-term adult disability. That means millions of Americans are not dying from stroke. They are surviving it, but never walking, speaking, or living independently again. Here is the part that changes everything. In the majority of cases, the brain does not go silent without warning. It sends you signals. Specific, identifiable, unmistakable signals. Sometimes hours before the main event. Sometimes days. And the overwhelming majority of people who receive those signals do exactly the same thing. They wait. They explain it away. They go back to their morning coffee and assume it was nothing. Thomas was 64 years old, a retired postal worker from Columbus, Ohio. He had never had a heart attack. His blood pressure was a little high, but nothing his doctor called alarming. One Tuesday morning, his left hand went numb for about 4 minutes while he was making breakfast. By the time he finished his eggs, the feeling had come back completely. He told no one. He assumed he had slept on it wrong. 11 days later, Thomas had a massive ischemic stroke. His left side was paralyzed for 7 months. Those 4 minutes were his window. He just did not know what they meant. This video is about making sure you do. My name is Dr. Chandler. I work in the field of gerontology and age-related disease prevention, specifically how the aging cardiovascular and neurological systems interact, and what that means for stroke risk in adults over 60. What I am going to show you today is not speculation. It is established neurovascular science, translated into language that is actually useful to you. A landmark review published in the Lancet Neurology confirmed that transient ischemic attacks, the brief warning episodes we will discuss today, precede nearly 1 in 4 major ischemic strokes. The same review found that 10 to 15% of patients who experienced a TIA went on to have a full stroke within 90 days. The highest risk window is the first 48 to 72 hours. That is the window this video is built around. Stay through to the end, because the 5th warning sign I am going to share is the one that surprises physicians themselves, and it is the sign most consistently dismissed as something else entirely. It is also the one with the most actionable window to act. A stroke does not come from nowhere. For the great majority of people over 60, it is the final measurable consequence of a process that has been building inside your arteries for years, sometimes for decades. The vessel wall has been quietly scarring. Cholesterol deposits have been layering. The channel through which blood flows to your brain has been narrowing. And at some point, the body begins to signal that the system is close to its limit. Those signals are what medicine calls transient ischemic attacks, TIAs. Transient simply means temporary. An artery briefly reduces blood flow to a region of your brain. That region goes partially offline. You feel a symptom. Then blood flow resumes, the symptom disappears, and your brain quietly sends you one last message before the damage becomes permanent. The tragedy is not that these warnings are invisible. The tragedy is that they are designed to feel like nothing. They are short. They resolve on their own. And without knowing what to look for, they register as a strange moment in your morning, not as a medical emergency. Let me walk you through the 5 warnings, exactly what they feel like, and exactly what is happening inside your brain when they occur. Warning sign number 1. One eye goes dark and comes back. You are standing at the kitchen counter. You look up, and the vision in your right eye, or your left, just disappears. Not blurry, gone. Like a shade being pulled down over a window. It lasts maybe 30 seconds, maybe 2 minutes. Then it comes back, clean and clear, and you think you simply had a strange moment. That moment has a clinical name, amaurosis fugax, Latin for fleeting blindness. And in the stroke world, it is treated as a 5-alarm fire. Here is what is actually happening. The ophthalmic artery, the vessel that delivers blood to your eye's retina, is a direct branch of the internal carotid artery, which is one of the 2 main highways carrying blood from your heart to your brain. When a small fragment of cholesterol plaque or a tiny blood clot breaks loose from a partially narrowed carotid artery and travels upward, it can briefly wedge into the ophthalmic artery. The retina loses its blood supply. You lose vision in that eye. When the fragment shifts and blood flow returns, your vision comes back. And here's the part that is genuinely terrifying. That exact same fragment, 2 millimeters to the side in its trajectory, enters a brain artery instead of the eye artery. At that point, you are not losing vision for 2 minutes. You are losing speech, or the use of your arm, or consciousness. Research published in Stroke, the Journal of the American Heart Association, found that patients presenting with amaurosis fugax have a 10-year cumulative stroke risk exceeding 15%. And that risk is heavily front-loaded in the first 90 days after the episode. Neurologists treat first-episode monocular blindness as a stroke equivalent requiring urgent vascular imaging of the carotid arteries. One episode of vision loss in one eye, not both eyes, one eye, that resolves on its own is a reason to call your doctor the same day. Not the same week, the same day. This is not anxiety. This is what the evidence tells us to do. Warning sign number 2 is one that sends millions of Americans to Google every year, but almost no one connects it to stroke risk. Warning sign number 2. One side of your body suddenly feels wrong. It might be your right hand going numb while you're reading the newspaper. Your left cheek suddenly feeling like it has been given a mild anesthetic at the dentist. Your entire left arm feeling heavy, rubbery, like it belongs to someone else. It comes without warning, with no change in position, no pressure on the limb. It lasts a few minutes, then it fades. The reflex explanation is almost always the same. I must have slept on it, or my circulation has been bad lately. Both of those explanations feel reasonable. Both of them are wrong in this context. When you compress a nerve by sleeping in an awkward position, you create a local interruption in nerve signal conduction. As soon as you move and release the pressure, sensation returns within seconds, and the process is symmetric. Both sides can be affected depending on posture. A TIA-related numbness works differently. The problem is not in the limb. The problem is in the somatosensory cortex, the strip of brain tissue that processes touch and sensation signals from the opposite side of the body. When blood flow to that cortical region drops, it stops processing sensation from one entire side. Not because anything is wrong with the arm or the hand, because the brain region that interprets signals from that arm has temporarily gone offline. This is why stroke symptoms are almost always one-sided. Each cerebral hemisphere maps to the opposite side of the body. Left hemisphere manages right side sensation and movement. Right hemisphere manages the left. When a vascular event hits one hemisphere, one side goes wrong. When both hands go numb evenly, the cause is almost always cervical. A spine issue, not a stroke signal. But when one side, just one, suddenly loses sensation for several minutes without positional trigger, that asymmetry is the flag. A 2020 analysis in JAMA Neurology reviewing over 4,500 TIA patients found that unilateral limb numbness was present in 38% of confirmed TIA cases, making it the second most common presenting symptom after speech disruption. The study noted that patients with this symptom alone had a 90-day stroke risk of 8.6%, comparable to patients presenting with more dramatic symptoms. 8.6% stroke risk within 90 days from a brief hand numbness episode that most people dismiss before they finish their morning coffee. Warning sign 3 involves your balance, and the explanation for it involves a part of your brain that most people have never heard of. Warning sign number 3, you suddenly cannot walk in a straight line. You stand up from a chair, or you take a step down from a curb, and for a brief moment, your leg lands in completely the wrong place. You grab the wall, you veer sideways on a flat, familiar surface, or you are hit by a violent spinning sensation so intense it makes you reach for something solid, even though you are sitting completely still. You blame the shoes, or blood pressure medication, or just getting older. And then it passes and life continues. The structure responsible for this symptom is the cerebellum, a dense, intricately folded region at the base and rear of your skull. Despite occupying only about 10% of your brain's volume, The cerebellum contains roughly half of all the neurons in the entire brain. Its function is continuous, real-time coordination, calculating where your body is in space, how hard each muscle group should fire with each step, and how to keep you upright when the ground is uneven or your position shifts suddenly. The cerebellum receives its blood supply from a set of arteries called the vertebrobasilar system, arteries that travel upward through the bones of your cervical spine into the back of your skull. When flow in those arteries drops sharply, even briefly, the cerebellum essentially misfires. The result is what neurologists describe as truncal ataxia, a sudden inability to coordinate movement, or acute vertigo that has no positional trigger. The critical distinction here is between benign positional dizziness and vascular dizziness. Benign positional vertigo is triggered by specific head movements, particularly rolling over in bed or looking sharply upward. It is caused by calcium crystals dislodging in the inner ear, not by impaired blood flow, and it follows predictable patterns. Vascular dizziness associated with a cerebellar TIA tends to arrive spontaneously, without head movement as a trigger, and often comes paired with other symptoms: sudden nausea, double vision lasting seconds, or difficulty swallowing briefly. Spontaneous severe dizziness plus any difficulty maintaining your gait, occurring together without a clear mechanical cause, should be evaluated as a possible vascular event until a physician rules it out with imaging. Not attributed to age. Evaluated. Warning sign number 4. Your words stop working. You are mid-sentence in a conversation and a word simply will not come. Not a tip-of-the-tongue moment. Everyone has those. What I am describing is qualitatively different. The word is completely absent, or it comes out distorted, tangled, unrecognizable, or you open your mouth and speak fluently, but what comes out makes no logical sense, and when someone responds, you cannot fully decode what they are saying back to you. There are 2 primary language regions in the human brain, both typically located in the left hemisphere. The first is Broca's area, involved in the production of speech, specifically in translating your intention to communicate into coordinated muscle movements of the tongue, lips, and jaw. When blood flow to this region is interrupted, even briefly, you may understand everything being said around you perfectly clearly, but you cannot get your own words out. They come out slurred, fragmented, or stuck. This is called expressive aphasia, and in a TIA, it resolves when blood flow returns. The second region is Wernicke's area, one responsible for the comprehension and internal organization of language. When this zone is temporarily underperfused, a person may speak at a perfectly normal rate and volume, producing fluent-sounding sentences, blah blah, but the content is incoherent. They may use the wrong words, create non-words, or string together phrases that have no logical relationship. And critically, they may not recognize that anything is wrong with their own speech. The Point trial published in the New England Journal of Medicine found that patients presenting with transient speech disruption, even episodes lasting under 5 minutes, had a 90-day major stroke risk of 13.6% when left untreated. The study demonstrated that appropriate treatment initiated within 12 hours of TIA symptom onset reduced that risk by 25%. That window of therapeutic opportunity opens and closes faster than most patients realize. A speech breakdown that self-corrects after a few minutes is not a reason to feel relieved. It is a reason to act within the hour. Speech disruption is one of the clearest cortical warning signals your brain can produce. Do not allow it to disappear without being evaluated. Warning sign 5 is the one that surprises even experienced clinicians. It involves a condition most people consider completely unrelated to stroke, and a symptom almost everyone normalizes after the age of 60. Warning sign number 5. The rhythm your heart is hiding from you. This is the warning sign that does not look like a warning sign at all. No sudden numbness, no vision change, no speech disruption. Instead, it is something most Americans over 60 have noticed at some point and assigned to coffee, stress, or aging: an occasional irregular heartbeat, a flutter, a brief sensation that your heart skipped a beat, or thumped too hard, or ran too fast for a moment and then settled. That pattern, intermittent, brief, self-resolving, is one of the most common presentations of atrial fibrillation. And atrial fibrillation is one of the most underappreciated stroke risk factors in American medicine today. Here is the mechanism. In a healthy heart rhythm, the upper chambers, the atria, contract in a coordinated, organized sequence that pushes blood efficiently into the lower chambers before it is pumped to the lungs and body. In atrial fibrillation, the atria stop contracting in an organized way. They quiver chaotically, sometimes firing at rates of 300 beats per minute or more, generating turbulent rather than smooth blood flow. In that churning, stagnating blood, particularly in a small pouch of the left atrium called the left atrial appendage, clots form. When those clots eject from the heart and travel through the carotid arteries to the brain, the result is what neurologists call a cardioembolic stroke. These strokes tend to be severe because the clots that form in the heart are larger than those that form locally in a narrowed brain artery. The reason this is warning sign 5 is that atrial fibrillation is frequently paroxysmal, meaning it comes and goes. It may be present for 30 seconds, an hour, or a few days, and then resolve completely. A standard 10-second ECG in a clinic, performed on a day when the rhythm has normalized, misses it entirely. The person leaves their annual physical with a clean heart record and continues to form clots intermittently. Research published in Circulation found that paroxysmal atrial fibrillation, the intermittent form, carries an equal stroke risk to persistent atrial fibrillation, despite being far more frequently missed on routine evaluation. The study estimated that up to 25% of ischemic strokes in adults over 65 are attributable to undiagnosed or undertreated atrial fibrillation. Continuous cardiac monitoring versus standard ECG increased detection rates by more than 300%. An occasional irregular heartbeat that resolves on its own is not something to dismiss because it went away. It is something to document: time of day, duration, associated symptoms, and bring to your physician with a specific request: extended cardiac monitoring, not a standard 10-second ECG. The distinction matters profoundly. Now, I want to tell you something that stroke neurologists discuss among themselves, but that rarely makes it into a standard patient conversation. After a transient ischemic attack, after any one of the 5 warning signs I just described, there is a biological window. Research consistently identifies it as 48 to 72 hours. That window is when the conditions that caused the warning episode are still active, unstable, and most susceptible to intervention. It is also, paradoxically, when most people are least likely to seek care, because the symptom resolved and they feel fine. The landmark ABCD2 score, developed from a study published in the Lancet, quantified exactly this. A patient presenting within 24 hours of a TIA episode and receiving urgent stroke workup had a 10-fold reduction in 90-day stroke risk compared to a patient who presented after a delay of several days. A 10-fold reduction, not from surgery, not from expensive intervention, from simply being evaluated urgently rather than later. What does that evaluation look like? There are 3 specific conversations worth initiating with your physician. Not, "I've been having some strange episodes," but 3 precise requests. The first, a carotid duplex ultrasound. This is an imaging study that shows both the anatomy of your neck arteries and the fluid dynamics of blood flowing through them. It detects plaque buildup, measures the degree of stenosis, narrowing, and identifies turbulent flow patterns that signal imminent risk. If your carotid is narrowed by more than 70%, that is a hemodynamically critical stenosis. That finding changes the conversation from monitoring to intervention. The second, the glycated hemoglobin test, HbA1c, not a fasting glucose. HbA1c measures the percentage of your red blood cells that have been chemically bonded to sugar over the past 3 months. It cannot be manipulated by one good day of eating before a blood draw. It tells you what your blood sugar environment has actually been. And it catches the pre-diabetic range where arterial damage is already occurring without any diagnosis on your chart. An HbA1c between 5.7 and 6.4% puts you in that damaging gray zone. Most people in that range have never been told they have a problem. The third, a 24-hour Holter monitor, an extended cardiac recording worn while you go about your normal daily routine. Because atrial fibrillation comes and goes, a 10-second ECG in a clinic is the equivalent of photographing the sky once and concluding it never rains. Extended monitoring captures the rhythm events that standard evaluation misses. If paroxysmal atrial fibrillation is identified, there are well-established anticoagulant medications that reduce cardioembolic stroke risk by 60 to 70%. That is not fate. That is a modifiable number. These three conversations, carotid ultrasound, HbA1c, extended cardiac monitoring, are not exotic specialist requests. They are standard tools. They simply require you to ask for them specifically rather than leaving a routine appointment with everything looks fine and no actual numbers in your hand. Thomas, the man from Columbus I told you about at the beginning, never had any of these three tests before his stroke. His carotid artery, we later learned, was narrowed by 78%. His HbA1c was 6.1. His atrial fibrillation was intermittent and had never been caught on a routine ECG. All three findings were present. All three were findable. None of them were found, because no one asked the right questions, and neither did he. Now you know the questions. That changes everything. Before you move on, I want to ask you something directly. Have you experienced any of the 5 warning signs I described today? Even once, even briefly, even months ago. Write it in the comments below, the sign, how long it lasted, and whether you had it evaluated. I read every comment, and your experience genuinely shapes what this channel covers next. Also tell me your age, because stroke risk after 60 is not a flat line. It changes meaningfully with each decade, and knowing who is in this audience helps me make the information as specific and useful as possible for exactly where you are right now. If this gave you something actionable today, something you are going to bring to your next doctor's appointment, hit subscribe. Because what I am covering in the coming weeks on blood pressure management after 70, on the specific sleep patterns that accelerate arterial aging, and on the cardiac markers your annual physical almost certainly is not measuring, it all connects to what we covered today. Each video builds on the last. There is one more thing you need to know before you leave this video. Everything we covered today, the clots, the narrowed arteries, the silent atrial fibrillation, shares a common upstream cause that most Americans over 60 are actively making worse every single day without realizing it. It is not cholesterol. It is not blood pressure. It is a specific inflammatory process happening inside your artery walls right now. And it is directly driven by 3 foods that the American nutritional conversation has called heart healthy for the last 30 years. That video is on your screen right now. Watch it next. What you find there will reframe everything you thought you knew about protecting your brain. I will see you in 60 seconds.